Good evening, friends. I'm Dr. Kaladar from Critical Care Department of Critical Care, Yashoda Hospitals, Malakpet. So we bring forth the Tuesday Masterclass webinar from the Department of Critical Care regularly more than 3.5 years. So these sessions where the students come on board, present the live cases in their unit, and the expert examiners across national platform, most of the examiners get involved. So because of which the active live discussion happens and the insights taken from them are very helpful. These webinars are posted on the Yashoda Masterclass platform in YouTube. The views, they have almost more than 5,000 views per each class on average. And most of the students have given feedback that these sessions are very helpful, especially during exams. They go through DRNB, DM, and even IDCCM across all exam platforms. And even practicing clinicians like intensivists, second tier cities, and especially second tier and third tier cities, they say these sessions are very helpful, and most of the times they log in and get very good clinical insights from these sessions. So without much delay, today's topic of discussion is ARDS. As everybody know, acute respiratory distress syndrome. We do see these patients day in and day out as a critical care physician, and almost forms a crux of the critical care around 20-25% of the cases. Everybody know the COVID pandemic, everything, it was about ARDS at that point of time. So we have two seasoned senior examiners and clinicians with us. We are privileged to have them on our platform. Dr. Ramesh Venkatraman sir is board certified internal medicine and critical care, American board certified. Sir is a senior consultant at Apollo Hospital, Chennai. The way he presents like tells any topic is so simplified, it is easy to understand. So I was there for the review course in Chennai. I heard that was the point around 2015. We were really very interested to listen to his class because very interesting way he puts forward the concepts. Thank you very much, sir, to come on board, and welcome you.
Thank you for the invitation, Kaladar.
Yes, sir. Thank you, sir. So I welcome Dr. Vinod Kumar Singh, sir. Sir is a senior. So sir is there as a co-chairperson at Institute of Critical Care Medicine, Sir Gangaram Hospital. Always very enthusiastic, and sir guides juniors just hand holding and guides like a friend. So I had seen him during my National ECMO conference held at the Yashoda hospitals the previous year. So very good lecture I heard from him, and I welcome you, sir. I think we get very good clinical insights from you.
Thank you, Dr. Kaladar.
Thank you, sir. So I welcome Dr. Pranita and Dr. Komali. Both are IDCCM students from Yashoda Hospitals, High-Tech City. So they are going to present the case, whatever they dealt with in their ICU. So Dr. Pranita and Komali, both of you can go ahead and present the case.
Good evening, Ramesh sir, Vinod sir, and Kaladar sir.
Good evening, sir.
With your permission, shall we begin the presentation, sir?
Yeah, sure. Go ahead.
So today we are discussing a 53-year-old male who presented with shortness of breath of grade 3 mmRC for 3 to 4 days, associated with cough, which is mucoid, for 3 days, associated with chest pain while coughing. No history of fever, travel, or contact to the sick patients. No comorbidities or any prior admissions. History of admission of 2 days at outside hospital for the similar complaints and treated as CAP. History of present illness. Complaints of shortness of breath, grade 3 mmRC for 3 to 4 days without orthopnea or PND. Cough with expectoration for 3 to 4 days, non-purulent, white color associated with right-sided chest pain while coughing. No history of fall, travel, community gathering, abdominal pain, or vomiting. History of binge alcohol consumption last week. Patient is a known chronic ethanolic. Past history, nothing contributory. Personal is a chronic alcoholic and tobacco chewer. Allergic history, no known drug allergies. General physical examination, patient moderately built and nourished, no pallor, icterus, clubbing, pedal edema, temperature of 97.3 degree Fahrenheit, pulse rate of 90 per minute, blood pressure of 130 by 90 millimeters of mercury, respiratory rate of 25 per minute, and saturation of 85% at NRBM of 15 liters per minute. Systemic examination, respiratory system, bilateral air entry were present, coarse crepitations in mammary, axillary, infraaxillary, interscapular, infrascapular area, cardiovascular system S1, S2 present without murmur, central nervous system, no altered sensorium or focal neurological deficit, per abdomen, soft bowel sounds were present. My provisional diagnosis would be aspiration pneumonia, community acquired pneumonia, or pulmonary edema.
So can I stop here for some time?
Yes, sir.
Can you go to the back slide where you have made a provisional diagnosis? Why you think the provisional diagnosis of aspiration pneumonia?
So patient who presented to us had a binge alcohol history 1 week ago, sir. After that, after 2 to 3 days, he had the symptoms and presented to outside hospital where he was already treated for treated as community acquired pneumonia, and then came to us, sir. We were suspecting it could be.
There are two prerequisites to diagnose aspiration pneumonia. One, the patient has got vomiting, and the second, the patient is not able to protect the airway.
Okay, sir.
So is at any point of time, whether your patient has got these two complaints. I think you have not mentioned about any of these complaints. The patient never had any altered sensorium?
No altered sensorium, sir, but patient couldn't remember whether he vomited or not, sir.
No, but you have not mentioned it in the history. You have not mentioned whether the patient has remembered the vomiting or not, or whether the patient was in altered sensorium or not. So if the patient is not fulfilling this prerequisite criteria, or even the patient is conscious, but somehow he's not maintaining the airway, not maintaining the airway protection, like patient with GBS, like the patient who has got a motor neuron disease, unless and until we'll give some clue that is suggestive that the patient has got a risk factor for aspiration pneumonia. Aspiration pneumonia, what I have understood is the gastric aspiration pneumonia. I believe what you want to say to me also.
Yes, sir.
So the patient never vomited, according to your history, and the patient never had any symptom or any sign suggestive that the patient has poor airway protection reflexes. So these patients will not have aspiration pneumonia. Or if you want to put the aspiration pneumonia as a provisional diagnosis, something should come in the clue, or something should come in the while you are presenting the patient and presenting complaint or history of presenting. Got my point?
Yes,
I'll
sir.
ask Dr. Ramesh also what is his view on
Yes,
the
sir.
provisional diagnosis of aspiration
No,
pneumonia.
yes, sir, I agree with you. There is not enough history to put aspiration pneumonia as number one. I would still go with
Yes.
community acquired pneumonia as number one. If you want, you can keep aspiration pneumonia down the list as a possibility, but maybe you can say, like sir said, lack of history is there. So that is something in the exam. I always will tell the trainees, say the answer that is not going to get you into trouble first. Community acquired pneumonia will not get you into trouble first, right? So since you put aspiration pneumonia, Dr. Vinod Singh asked you questions about aspiration pneumonia. So always try to say the most non-controversial statement first. So nobody would argue fever, cough, sputum, worsening shortness of breath, and hypoxemia. If you just say community acquired pneumonia, first diagnosis, you are done. Second and third, you can always discuss based on the history. So that's not specifically, but generally try to say a non-controversial statement first, and then go on to more and more difficult things to defend. Because if you get stuck in the first bullet, then you will not get back to the second and third and the fourth questions in the exam. You may not have time. So I agree with Dr. Singh. I probably wouldn't have put aspiration pneumonia as number one. Can you go back 2-3 slides before, please? Yeah. one more before. Yeah. Next one. Okay, one thing. Be careful about, I mean, this is again just the way I think about it. Be careful about calling anybody an ethanolic. Just because somebody drinks, they don't become an ethanolic, right? People can use alcohol for many years and not be an ethanolic. So there are specific criteria before you call somebody an ethanolic, not for the exam point of view, but at the bedside. No, if I am a patient lying down and I happen to drink every day a glass of wine or two, maybe a beer at the end of the day, calling me an ethanolic, I would get hurt. So try to avoid that. You can say chronic ethanol user or chronic tobacco user. I think that would be a better way of calling patients than an ethanolic. The next slide, please.
Okay, sir.
So when you have somebody with a saturation of 85% on a non-rebreathing mask, what do you think is happening pathophysiologically?
Hypoxia, sir. Severe hypoxia. He's with an RBM of 15, in the sense with FiO2 of even 60 to 80%. 80, it is he's still attaining less than 90, sir.
Definitely, this is hypoxia. But pathophysiologically, what do you think is the cause of hypoxia in this patient?
So we on auscultation we had bilateral coarse crepitation, sir. So I was suspecting there were it was alveolar edema or any plugging.
So pathophysiologically, what do you call it? You're telling me the mechanisms, but pathophysiologically, what would you call this? This is the maximum oxygen you can give to anybody, right? So this is what we would call refractory hypoxemia. Somebody is not responding to oxygen. So what is the likely mechanism?
Shunt mechanism.
Very good. Shunt mechanism.
Shunt.
That automatically tells you that there is at least a 40% shunt in the lung, 30 to 40% shunt, because they are not responding to oxygen. That's a classic hallmark of shunt physiology. The mechanism, like Dr. Pranitha said, is possibly because of fluid in the alveoli or collapse or multiple other things where that is causing a shunt physiology, right? So in somebody with a shunt physiology, what strategy would you try to think of to improve their oxygenation?
Positive pressure.
Positive.
Very good. Positive pressure ventilation.
Positive pressure ventilation. That is what we do.
Yes. Okay, good. So this patient is going to automatically need positive pressure ventilation. No point in getting a blood gas or doing any other things. You're going to go for a positive pressure ventilation. Keep going forward. One slide.
Just the
diagnosis.
Yeah, Dr. Ramesh, continue.
Next slide, please. I'm going to ask you, why did you think of acute pulmonary edema in this patient? You told me there was no orthopnea PND in the history, no cardiac history from what you could tell, no chest pain. The chest pain was only on the right side when he coughed, right? Based on what you gave me the history. So like Dr. Vinod Singh asked, what made you think of pulmonary edema as the second choice in this patient?
Desaturation and diffuse crepitation.
Severe hypoxemia and associated infiltrates kind of picture, sir.
No, you have not seen any infiltrates. Just we are talking about the history. So in your history, is there any risk factor for development of pulmonary edema? You have mentioned no, there is no any history of. Is there any irregular heart rate or it is a sinus pulse you have told? So there is no anything should lead to pulmonary edema. Okay, and even the history is not suggestive of pulmonary edema. So it is not a problem, whatever provisional diagnosis you are writing in the exam or telling, you must explain that why you are suspecting a pulmonary edema. Okay. So if somebody asks me that, I can tell that, okay, the patient might have got some chest infection, which has precipitated a decompensated heart failure. That could be the one answer that you can also keep in mind while writing the pulmonary edema. So it could be a combination of pneumonia as well as pulmonary edema, because the infection might have precipitated the heart failure, acute heart failure, which was not there at that time. That could be one answer that we can later prove or disprove. But what at this stage, I want to say, whatever you want to write as a provisional diagnosis, you must have at least 2 points to prove your diagnosis at that time. Just like if somebody asks me aspiration pneumonia, then it should have 1 or 2 points to ask him for that. Okay. Even you write a community-acquired pneumonia, that will be okay with me, that whatever the point you have written, it is going in favor of pulmonary, community-acquired pneumonia. Now, the second thing what I want to emphasize here is that you have written the provisional diagnosis, why your patient has come to the ICU, because the patient has got respiratory failure. So one of the things which is mentioned at this stage is that the patient had acute respiratory failure, hypoxemic respiratory failure, or acute respiratory failure. We have not done the ABG, but the clinical signs are suggestive of respiratory failure. So that could be one of the diagnoses also, because respiratory failure is diagnosis. If the patient is having all the signs, symptoms, is not. That is the thing. So whatever the provisional diagnosis you write, you must write if you have to explain before the examiner. Okay. Like if you've written acute pulmonary edema, the probably explanation is that the infection or the pneumonia might have precipitated some heart failure leading to pulmonary edema. So a combination of pneumonia and pulmonary edema, which is quite possible in ICU. Okay.
Okay.
Please proceed.
So chest X-ray. So chest X-ray view showing the bilateral diffuse non-homogeneous opacities more over the right, with upper, mid, and lower zone in the right and mid and lower zone in the left. So
why you are telling it is AP view? If examiner asks you why you are telling AP view?
patient was fine, sir.
Tell me 2-3 points. Somebody can ask always why you are telling AP view. Tell me 2 points.
The scapula, sir, scapula border, which is overlapped, and angle of the clavicle, sir, and
So if we can see here that some ECG things are put here, ECG button visible here in left side and right side. And actually a scapula, if you ask me very frankly, it should be in the lung field in AP view. And in PA view, it should be totally out of the lung field. Because what you do in PA, you are just holding the plate like this. So it is totally lateral, bilateral scapula, while it is in the lung field in the AP view. Anyway, this is just a question. Okay, you can proceed further.
so ECG was normal sinus rhythm, and the ABG pH of 7.48, PaCO2 of 38.6 mm of mercury, and PaO2 of 57.2, bicarb of 27.8, PF ratio of on NIV, sir, FiO2 of 0.4, PF ratio of 142, with pressure support 8 and PEEP of 8, sir. The Hakar score was 4. 2D echo showed no regional wall motion abnormality, normal size chambers, no effusion, ejection fraction was 61%, normal LV systolic function, right ventricular systolic pressure 18 mm of mercury, grade 2 diastolic dysfunction, IVC was normal, no clots or vegetations.
Can I pause you here and ask you a question? Do you think NIV was a good initial choice in this patient based on whatever information you have given us? Do you agree or do you disagree?
NIV we usually don't use, sir, but here in our case we have our patient attender was not ready for the intubation, sir. So we had to proceed with the NIV only.
Fair enough, right? This is not a level 1 indication for NIV. And looking at that X-ray, it doesn't look like it's a process that is going to resolve quickly also, right? It is going to take a long time. So maybe not a good candidate for NIV, especially if you thought he was aspirating after vomiting. Okay, so fair enough. No, they couldn't afford, so you put him on NIV. Yeah. Continue.
Okay, sir. So this was the CT of the case, so showing a bilateral dense non-homogeneous opacities with air bronchograms.
See, just go to the, when we describe CT, we never describe like X-ray. Non-homogeneous opacity is the description of X-ray. It is not the description of CT. So you must learn how to describe opacity in the CT and how to describe opacity in the. So it is bilateral dense consolidation. If you look at the CT, there are a lot of air bronchogram. Just look at the CT. You can look at again. You can find that there is a bilateral consolidation which is visible in the CT scan, and it is more on the right side. There are so many findings also, but the gross finding is that there is a bilateral consolidation with air bronchogram that you can see, and the infiltrates also. So non-homogeneous opacity is the description in the
Yes,
chest
sir.
X-ray. It is never a description in the CT scan. So try to remember those terms which is used in the X-ray, those terms which are used in the CT scan, just CT scan. Okay.
Yes, sir.
Yes.
Investigation, sir. Hemoglobin of 11 gram per deciliter, RBC of 3.9 million per cubic mm, platelet of 2.9 lakhs per cubic mm, WBC of 7,470 cells per cubic mm, ESR of 50 and CRP of 294.2. LFT with and RFT were within normal limits, PT of 17.6, INR of 1.32. Electrolytes were within normal limits. NT-proBNP was sent, which was 2,440, and HCV, HIV, SBS, AG was negative, sir. Treatment, we have started him on cefoperazone sulbactam of 1.2 gram IV twice a day with clarithromycin of 500 mg IV twice a day with oseltamivir of 75 mg twice a day, and anticoagulation with injection dalteparin 5000 units subcutaneous once a day, and injection furosemide 20 mg IV twice a day. Patient was on when shifted to ICU, patient was on NIV, FiO2 of 60%, PEEP of 10, and pressure support of 12.
So can I stop here?
Yes.
So what is the diagnosis at present?
So
Your
this
patient is ARDS?
yes, sir. This is moderately severe ARDS, sir, with type 1 respiratory failure, secondary to query community acquired or aspiration.
So you have to be very clear in mind that my patient has got ARDS now. Whatever may be the cause, and one cause what you are telling is that this is secondary to community acquired pneumonia. And severity wise, because PF ratio is around 143, what is the initial PF ratio? So it is a moderate ARDS.
Yes, sir.
Okay, according to the Berlin definition.
Yes.
So what are the criteria for ARDS in Berlin definition? And how many criteria your patient is fulfilling?
So criteria of Berlin definition is, sir, acute onset, less than up to 7 days of known insult or a new or worsening hypoxia, respiratory distress, sir, and patient of P by PO2 by P by F ratios of less than 300, which is mild, 200 to 300, 100 to 200 is moderate, less than 100 is severe, sir, and uh, imaging showing bilateral infiltrates, opacities, which is not explained either by effusion, collapse, or nodules, and edema, which is not explained by cardiac, fluid overload or cardiac failure.
So, if the patient is not on NIV, so how do you modify the definition to accept the patient is in ARDS?
Or if it's not on NIV, so the new Kigali modification, so where we see HFNC of 30 liters per minute, or SPO2 by FiO2 ratio so of less than 313 with the saturation of less than 97%. So
Fine. So now we are treating a patient who has got a pneumonia and he has developed a pneumonia complicated by ARDS. Is that correct?
Yes, sir.
And this is a moderate ARDS according to
Yes.
Butler criteria.
Yes, sir.
And
Okay.
just, I mean, a lot of people in the audience also asked, I think it's a typo, right? It's cephalosporin sulbactam of 1.5 grams, right?
Yes.
Yes, sir.
It's not 1.2, it is
It is
1.5.
printing, I mean, typing error.
Yeah.
Okay.
And
no
and
problem.
why 1.5 grams? Was this renal function normal or abnormal? I missed that part. I'm sorry.
It was normal, sir. Renal function was normal, sir.
Do you agree with the dose then?
We have kept it 1.5. So this treatment was before we got the investigations and we continued that.
Anyway, what should be the optimal dose for cephalosporin sulbactam in an adult patient around 60-70 kg and who is not having a normal renal function?
1.5 gram TID dose.
Is it given 8 hourly or 12 hour?
8 hourly we can give, sir, if there is no renal
Usually given
function.
12 hourly cephalosporin sulbactam.
Okay.
And 3 gram 12 hourly. I'd like to ask Dr. Ramesh also.
Yeah, we give 3 grams 12th hourly.
12 hourly, 3 grams 12 hourly is the optimal dose of the cephalosporin sulbactam combination.
Keep going.
Continue.
ABG after 2 hours, sir. So pH was 7.46 and PCO2 of 40 mm of Hg, PaO2 of 16 mm of Hg, bicarb of 28 moles, and FiO2 of 0.5 with PF ratios dropping to 132 and HACR score of 4.
So what is the metabolic abnormality in this ABG?
Showing a metabolic alkalosis, sir, with
Why your patient
type
has
1
got-
respiratory failure. Because we have started on furosemide, sir.
Fine. You have started furosemide, so that might lead to the development of metabolic alkalosis. Fine.
So this was the day 1. This was the day 2 X-ray, sir, showing bilateral non-homogeneous opacities and more predominantly in the right rather than left lung, with ABG of pH 7.45, PaCO2 of 44, and PaO2 of 68, bicarb of 28, on FiO2 of 0.6, and PF ratio dropping to 113. So here the HACR score was 5.
So just for the audience, what is the clinical importance of HACR score?
So after initiation of NIV, sir, we check the HACR score to see the NIV failure. So when to intubate the patient, he is in failure. So if the HACR score is around 4.8, I mean, it is less than 5, it is low risk, sir. If 5 and above, it is high risk, sir. We should change to the different modality of intubation, of ventilation.
You have to intubate.
We have to intubate, sir.
Yes, you have to put. We'll consider this is a failure of the NIV.
Yes, sir.
It is usually used in the hypoxemic respiratory failure. This may not be applicable to the COPD patient or type 2 respiratory patient, failure patient. So this is applicable to acute hypoxemic respiratory failure, those who are the NIV.
For the sake of the audience, can you tell me what variables are there in HACR?
So heart rate, sir, and arterial pH, and level of consciousness, and of PF ratios and respiratory rates, sir.
Okay, good. Keep going.
Okay, sir. So the day 2 investigations, HB of 9.8, sir, RBC of 3.5 million per cubic mm, platelet of 2.97 lakhs per cubic mm, WBC of 8,690 cells per cubic mm, and CRP from 240s to 180 milligram per liter, and RFT was within normal limit. HbA1c was also 5.7, sir. Patient was intubated. Patient attenders were counseled because of the NIV failure and was intubated electively with volume control mode. His predicted body weight of 72 kgs. Started on FiO2 of 1, sir. PEEP of 10, and tidal volume was 420, and respiratory rate for 20. The plateau pressure was 26, and driving pressure was 16, sir.
So just a quick question. How did you calculate the predicted body weight?
Predicted body weight, there's a formula, sir, for male patients. It is
No, how did you
50.
get his height? Did you ask the family what his height was? How did you get the height? What do you normally do in your ICU?
So we have asked the family, sir, his height, and we converted. So
You generally ask the family the height, right?
right.
The better option would be to measure the height yourself to be more accurate. So that is something maybe you can look up into. There are 3 or 4 methods of how you can actually measure the height. So that is something that at least ARDS patients, somebody should be doing it at the time of initiation of ventilation to have accurate predicted body weight.
Okay, sir.
Yeah. So you said plateau pressure is 26, driving pressure is 16. Any other parameter on the ventilator that is important in terms of oxygenation? This patient's main issue is oxygenation, right?
Yes, sir.
Any other parameter on the ventilator that you would note down that would affect your oxygenation?
PEEP.
One is FiO2. FiO2 will
Yes,
affect
sir.
your oxygenation. Anything else will affect your oxygenation?
What is the PEEP you have used in this?
10, sir.
Okay, so what Dr. Ramesh might be asking that from where you have got the figure of 10 to use in your patient?
No, sir. I was just trying to see that mean airway pressure. No, that's something
Yeah,
that
mean airway pressure also they have not
Yeah.
mentioned it. Yeah.
So mean airway pressure is something you should look at because the 2 determinants of oxygenation would be mean airway pressure and FiO2. And you can moderate, I mean, you can augment the mean airway pressure by several ways, one of which is also going to be PEEP. So it will be good for you to keep a note of mean airway pressure because every time you titrate something, you're also going to see if the mean airway pressure is changing or not. So that is something that you should get into the habit of looking.
Okay, sir.
Okay, so yes. Yeah, continue, doctor.
Okay. So ABG was repeated after an hour
No,
of
we'll go to backslide. We'll go to backslide. Just come. I'm just asking, besides the mean airway pressure, how do you set PEEP in your patient? How you have started with PEEP of 10? And why you have started with PEEP of 10?
So my patient was generating tidal volumes enough, sir, with that PEEP and without any. He was maintaining saturations around 90, sir. So I sticked to PEEP of 10, sir.
So anyway, what are the standard method to use PEEP in ARDS patient?
So PEEP titration tables, sir.
PEEP titration table 1, where you use PEEP FiO2 table. Is it whether it is a higher PEEP or lower PEEP table? That is 1. You are not fitting in that table. So what are the other methods? One is PEEP titration, we have already told. What is the other methods? How do you use the PEEP in your patient, ventilated patient? PEEP titration, maybe you are using a stress index also, some people are doing. Some people are also showing what is the impact of PEEP and the plateau pressure, okay? And maybe also sometime you titrate according to the oxygenation, which is the best oxygenation between PEEP and the impact on the hemodynamic. So there are several, maybe ultrasound also some people are using what is the, whether it is recruitment is there by using the PEEP or not. We are not recruiting, but using the ultrasound and B line, we can see that. So there are several methods to utilize the PEEP in the ARDS patient. One, what is the relevance of driving pressure? As there is a relevance of mean airway pressure, there is a relevance of driving pressure also.
So lung injury, so
Any idea why driving pressure and what is the limit of the driving pressure? How it came to concept in management of ARDS patient?
we try to maintain below 15, so below 14, 15 to avoid the alveolar injury.
Okay, okay, fine. We'll go ahead.
Can I elaborate on that a little bit, sir, just to explain?
Yes, yes, Dr. Ramesh.
So just to explain the concept, just take that opportunity to explain the concept since we talked about it, right? So the original idea was to set tidal volume based on predicted body weight. All of you would know the ARDS original ARDS-NET trial where they randomized patients to 6 and 12 ml and showed that 6 had a better survival than 12. So based on that, everybody subsequently started practicing 6 ml per predicted body weight based on your height using the formula that you just mentioned, right? But
Yes.
let's say I am 70 kilos and another patient is also 70 kilos per predicted body weight. So both of us should get 420 ml tidal volume, right? But our degree of lung injury or ARDS can be different. I may have more severe ARDS, the other person may have a milder ARDS, which means my normal lung will be very less. Most of my lung would be abnormal. When I say abnormal, it will have very, very poor compliance. And a person who's got a milder ARDS will have more normal lung and less abnormal lung than me. Now, you're going to give 420 ml to both the lungs. I have very little normal lung, a lot of stiff lung. Somebody else has a good amount of normal lung and a good amount of stiff lung. So if I just set one tidal volume for everybody based on weight, it would probably be too much for somebody like me with a very little normal lung because most of the tidal volume will go to the normal lung because the rest of the lung is very, very stiff. Right? So I would get 420 ml tidal volume into a small area of normal lung versus somebody else with a milder ARDS would get 420 ml of tidal volume into a slightly more areas of normal lung. So therefore, their lung injury would be less compared to lung injury that you create for me. So there must be some mechanism for me to look at tidal volume corrected to my normal lung volume, right? But there is no way for us to know what the normal lung volume for any ARDS is, right? So if you look at compliance, volume, and pressure, if I know the compliance and volume, I will get the pressure. If I have more normal lung, my compliance will be low. Therefore, my driving pressure will be low. If I have a very poor compliance, then my driving pressure will be high. So driving pressure indirectly tells you how much of normal lung you have and how much tidal volume you are putting into that normal lung. It is a tidal volume corrected to the amount of normal lung or compliant lung you have. Does that make sense?
Yes, sir.
So driving pressure, you are right, causes more lung injury, but it is a surrogate marker for the tidal volume corrected to the normal compliant lung that the patient has because there is no other way to look at it. And the number 15 is a retrospectively derived number based on the Amato study in Brazil where they looked and said, okay, above 15, mortality seems to go up. So we should definitely keep it below 15. But the message I think all of you should get is you should go to the lowest driving pressure possible to oxygenate and ventilate somebody. So just because somebody is 15 or 14, you should not be happy and stop there. You should continue to see if I can get the driving pressure down to the lowest driving pressure possible. The upper limit is 15, but there is no lower limit. Keep going down because the less the driving pressure, less the lung injury overall. So keep working your way down if you are able to oxygenate and ventilate the patient. So I just thought since Dr. Vinod brought the very important concept, it's worthwhile taking 2 minutes to just explain for the sake of the audience. Continue, please. Sir, you want to add anything, sir?
No. Fine. Very good. Explained. Very good.
Next slide, please.
So ABG was done after an hour of intubation, so pH of 7.33, PeCO2 of 61 mm of mercury, PaO2 of 109 mm of mercury, and bicarb of 31 millimole per liter, lactate of 0.6, which was on FiO2 of 0.7, sir, from 1. PF ratios has improved from 113 to 155, sir. And with the worsening respiratory.
I'm just going to stop there before you go to paralytics. So I have set the initial setting. The previous slide, you have the initial setting, right? Can you just
Yes.
go back to the previous slide? So just for everybody, rate of 20, 420 tidal volume, 100% FiO2, 10 of PEEP, flat 2 is 26, driving pressure is 16. And then the next slide, please. This is the ABG, the first ABG you get. So at the bedside, how do you decide I'm going in the right direction or do I need to change my vent settings now? How do you make the decision? Before even you go to paralytics, you have just put the patient on a ventilator, you have got the first gas. Are you happy? Are you not happy? If you're happy, why? If you're not happy, what are you not happy about? Only then I have to decide I need to change something, right? If I'm happy, I'm just going to leave the patient alone.
Yes, sir. So the patient has developed a respiratory acidosis, sir, with type 2 failure here. And we are the better part was we were able to come down on FiO2 from 1 to 0.7, sir. And the PF ratios improved from 113 to 155, sir.
All the numbers are there. Are you happy or unhappy?
Is it acceptable or not?
Yeah.
In patients with ARDS whom we are ventilating, this ABG is acceptable or you want to do something?
Increasing respiratory rate to wash out CO2, sir.
Why you want to wash out the CO2? Because pH is in the acceptable range, and if you go to the ARMA trial and all the trial of lung protective ventilation, there is a concept of permissible hypercarbia. So if we know this concept and my pH is 7.33, so why we are worried about the PCO2 of 61? If you want to increase the tidal volume or if you want to increase the respiratory rate, probably might create some more other problem also to the patient. So is there anything worried? Or are you worrying for high PCO2 in your patient? Looking at this ABG? To me, I accept it. I'm not worried about this level of PCO2. In fact, I'm happy that okay, my patient's PCO2 is 60, 61. That means the tidal volume I'm giving to your patient is okay, fine. I'm more worried about, you have not mentioned, already you have mentioned, I think, plateau pressure and driving pressure. That is also acceptable. Okay, I'll also ask to Dr. Ramesh, is he worried about this ABG?
No, I'm not worried also. I completely agree with Dr. Singh here. So before you react to any ventilator change in ARDS, I ask myself two things. What are the goals, endpoints that I need to achieve with ventilation? Saturation goal. What is the saturation goal in ARDS?
So
what saturation would you accept in ARDS patient?
88.
Saturation of above 88, sir.
Okay, saturation of above 88. So this patient has clearly got a saturation of above 88. 2. In terms of when you say saturation, how much FiO2 do you want to come down to say that I'm doing a good job of oxygenating the patient? You are happy with 70% FiO2?
Yes.
So what FiO2 would make you feel?
It's the target FiO2 want to achieve.
0.4, sir.
Most people will say less than 60%, right? Less than 60%, most people would say is acceptable because beyond that, the oxygen-induced toxicity is probably not that high, lower than that, right? That's number 2. 3, for PCO2, we don't worry about the PCO2, we worry about the pH. Dr. Vinod Singh clearly said that, right? What pH would you accept?
7.3, sir, and if it is falling, we'll increase the respiratory rate to.
So when we say permissive hypercapnia, we go up to 7.25, right? There are very few patients where we can't do permissive hypercapnia. We won't go there. But in general ARDS, your targets are going to be pH more than 7.25, saturation more than 88, and FiO2 less than 60. In this patient, potentially you can get the FiO2 to less than 60%, or at least go to 60% in the next step, right? That is number one. So these are the endpoints. Second question I have to ask myself is, am I harming the lung? What are the endpoints of that you will be careful about, where you will say, okay, if I breach these endpoints, I'm going to be harming the lung? Can you tell me some parameters that would make you worried about harming the lung or injuring the lung more?
So I raise in my driving pressure, sir.
Okay. So driving pressure is one. Some people may say plateau pressure of the 35 or 30 or above, not even 35, 30 or above, and driving pressure of 16. So this patient, do you think, are you injuring the lung more than you would like to?
No, sir.
Your driving pressure was 16, right?
Yes, sir. Previously 16 and now.
That is high. That is high, right? You want to come down on the driving pressure. So I look at two things. Have I reached my endpoints comfortably? Am I harming the lung? If the question to both is yes, I am not harming the lung and I have achieved all my endpoints, then I'm okay. I'm ventilating the patient adequately. I don't need to do anything fancy. But if I am not meeting my endpoints, or like in this patient, I can meet the endpoints, but I'm injuring the lung, then I need to do something different so that I ventilate the patient better. Does that make sense?
Yes, sir.
Okay, so that is the way you need to think parallelly when it comes to ARDS.
Okay, sir.
All right.
So patient
Now,
was
for this ABG and these parameters, what end changes would you consider?
Ideally, sir, we will be titrating with the respiratory rate, sir, increasing the respiratory rate, and looking at the pH.
pH is already above 7.25, right? Both Dr. Singh and myself said we are not worried about that pH. So 7.33, I'll be very happy. I don't need to increase my minute volume any further, right? So things I would consider is one, coming down on the FiO2, keeping eye on the saturation, and I have to do something for the high driving pressure. What can I do for the high driving pressure?
Increasing PEEP.
PEEP titration.
No, you said something. Please go ahead, repeat it again.
PEEP.
Don't worry about being wrong. It's just a practice. So go ahead and tell us whatever you feel like. So we can correct it if you're wrong.
PEEP, sir.
PEEP.
PEEP titration.
What would you do to PEEP to decrease the driving pressure?
We will increase, sir.
So what is the effect of PEEP on driving pressure?
If increasing PEEP, if driving pressure reduces, that means
Then
recruitment
optimal
of
PEEP.
alveoli are there.
So the effect of PEEP on driving pressure is variable, right? If I
Yes.
increase my PEEP and my driving pressure goes down, which means that I am recruiting more lung, opening more alveoli, that is good. And that is one of the ways of titrating PEEP, to keep going down to get a driving pressure lower. On the other hand, if I increase my PEEP and my driving pressure goes up, what does that mean?
Over distension of
Overdistension.
alveoli.
Overdistension, and you're
Lung
harming the
injury.
lung more, right? So one, I can try to decrease my FiO2. Two, you can gently increase your PEEP and see what happens to your driving pressure and then reassess the patient. So both those options are appropriate for this particular ABG. Okay, continue,
Yes.
please.
So patient was paralyzed with a tracheuria of 25 mg per hour, sir, and the patient was continued with volume control mode of FiO2 0.7. PEEP was increased to 14 and tidal volume 420 and respiratory rate of 24, sir. With this, we could achieve plateau pressures of 28 and driving pressures of 16, sir. 14, sir.
Yeah.
Go ahead.
A sputum was sent on the first day, sir, day 1, which revealed very few epithelial and few volume of gram-positive cocci in pair and short chains, budding yeast cell. LRTI lower respiratory tract PCR panel was sent, sir, post intubation, which came negative, sir.
So why do you paralyze these patients?
to
Is there any
decrease.
evidence to paralyze a patients with like this in ARDS?
No, yes, so the Accurasis trial, so
Okay.
which had shown the improved outcomes, sir, and mortality benefit.
Do you know of any other study?
Rose petal, sir, which was done later, which showed it does not affect
I'm sorry, which one? Second one, you said?
rose trial, sir.
Rose trial. So the Accurasis showed mortality benefit while Rose did not, right?
Yes, sir.
Why do you think that was the case?
In rose petal, they use lower sedation in control groups, and they recruited early enrollment of ARDS cases. The difference.
And in Accurasis, the PEEP was also lower. So maybe they didn't ventilate better. Why do you actually paralyze patients? What are the reasons why would you want to paralyze patients? Yes, 2 studies showed opposite results. So I really don't know whether it actually improves mortality or not. But still, most of us paralyze in these kinds of patients. Why would you paralyze?
To achieve, I mean, if there is a patient ventilator dysynchronous, to overcome that, so.
Very good. To overcome patient ventilator dysynchronous.
Any other reason why you paralyze the patient? One, usually ARDS patient, if you go for sedation and if you even don't have a patient ventilator synchrony, any other concept of paralyzing the patient of acute lung injury, probably the severe acute lung injury? What are the problem with if the patient starts with continue with the breathing with the ARDS patient? What is self-induced lung injury or the silly must have known? So there is one thing also you can prevent the silly if the patient is because their oxygen requirement and their ventilation requirements are very high. Sometimes they generate very high negative pressure to assess the assessed control mode. So one way the physiologically that we can minimize the silly. So paralysis has got benefit as well as the harm also. What is the harm of paralyzing the patient?
Prolonged paralysis will lead to muscular weakness.
ICU acquired.
ICU
They are
acquired.
one of the factor for ICU acquired. Okay. Okay, you can go ahead.
Okay.
Please go ahead. Yeah.
So after 6 hours, sir, patient was an FiO2 of 1. PEEP increased from 14 to 18, sir. Tidal volume of 420, respiratory rate of 25. The plateau pressures were 35 and the driving pressure increased from 14 to 17. The ABG showed 7.41 pH. PaCO2 has come down to 48 and PaO2 of 106, sir. Bicarb of 30. PF ratios have fallen to 106, sir.
So when this happens, suddenly the oxygenation has gotten worse. You've used a higher PEEP, plateau pressure has gone up, driving pressure has gone up. What are the reasons why this could happen? What are the clinical reasons why suddenly this is happening after 6 hours? What are the possibilities you should think of?
So pneumothorax could be one of the possibilities, sir.
Good.
And PT, sir.
Would thromboembolism cause a high plateau pressure and driving pressure?
No, sir. Hypoxia, acute hypoxia, acute.
No, we are talking about this entire picture, right? More hypoxia, need for more PEEP, higher plateau, higher driving pressure. One is pneumothorax. Anything else?
Worsening of underlying.
Very good. Worsening
Pneumonia.
underlying disease, possible. Yes. Anything else? So what happens to your overall respiratory complaints when you paralyze somebody?
Complaints improve.
It can vary, right? If there is no spontaneous efforts, the negative pleural pressure is gone. There can be worsening compliance that can just be a part of just immediate post-paralysis also. Just remember that. And things like tube migration, you should never miss those things, right? Tube could have migrated between then and now. And always think outside the chest. Abdomen, right? Abdominal distension could have happened by now. So you got to be careful whether there was an NG tube in place. Is it draining well? Abdomen could be the other reason why all your pressures are getting worse. So when you have a patient with all this happening, you should think of all the possible reasons that can contribute to such a picture.
So,
Okay, go ahead, continue.
so with this patient was prone, sir, with FiO2 of 1, PEEP of 18, tidal volume 420, and respiratory 25, plat of 35, and driving pressure 17, sir. And our ABG was repeated after 6 hours of proning, which showed pH was 7.5, PaCO2 of 43, PaO2 of 156, sir, and bicarb of 33. We could achieve FiO2 of 0.5. PEEP was 12, sir. Tidal volume 420, respiratory rate of 25. PEEP plat, we could come down from 35 to 24, sir, and driving pressures to 14, sir.
You want to tell us how proning helps? Just why do you think suddenly there is an improvement? What happens when you prone somebody, and why does it help oxygenation? Or
So we will be lifting off the compression pressure of the mediastinum and the heart, sir, and then allowing the dorsal portion of the lung to have a homogeneous ventilation, sir.
Proper drainage of secretions and perfusion.
fine.
So according to you, your patient was prone and the patient improved. So what are the criteria for improvement after proning?
P by F more than 150 and PEEP less than 10.
According to the Provisional trial, so it is PF ratio of greater than 150 and PaO2 of greater than 60 and saturation of above 90. So
this is the indication for proning.
no, sir, this is the trial what they have
This
tried.
is the trial, and this is the indication in trial, Provisional trial, to prone the patient. Once the patient, you optimize the patient hemodynamically, and if the patient is hemodynamically stable, then you prone the patient. That's how the Provisional has narrated their trial. And how do you say that your patient has improved after proning?
So we could come down on FiO2, sir, as well as the plateau pressures and PEEP, sir. With also the driving pressures have come down.
So in Provisional,
improvement in the ABG.
Discuss about the PEEP, driving pressure and plateau pressure. They have discussed. We have come down with the FiO2, and there is improvement in the oxygen saturation. What they have discussed. Okay. Now, when do you say that your proning has failed?
More
That
more
is
than
my-
20%.
Sorry.
More than 20% drop in PaO2.
So if there is no improvement in the proning in PO2 FiO2 ratio, after how much proning? What is the time? 1, 2, 3 proning?
More than 2.
Trials.
So there is no clear-cut guide. Okay. So suppose your patient, you prone the patient and your patient improved. Okay. Suppose the patient would not have improved at that time. What is the option?
We'll supine the patient and go for
Okay.
ECMO.
So if the patient has failed on proning, what are the options we have?
PEEP.
So after recruitment and PEEP titration and prone, sir, the next option is ECMO, sir.
Just a minute. Do you go for recruitment in ARDS nowadays?
We try initially, sir, and after proning also there is no improvement. We go for ECMO, sir.
ECMO. So if the patient has failed on proning, then we have to go on ECMO. That is the VV ECMO. That is the only option which, according to the guideline, or according to the whatever the protocol for the ARDS management, we don't recruit the ARDS patient. And again, I will ask you, Dr. Ramesh, is he happy with recruiting the patient, acute recruitment in ARDS patient?
No, based on the current evidence, I would not recruit an ARDS lung. ECMO is an option, but if I have an option of inhaled nitric oxide, I would try that because you already recruited the alveoli, hopefully, as much as you can with proning and adequate PEEP. Nitric oxide will recruit your blood vessels, right? That's the other part that I can work on. So I have done my part with the alveoli. I would try to do on the vascular side with the inhaled nitric oxide or prostaglandin. I mean, some centers use it. We use nitric oxide. You could try with proning and see if that helps. If not, like I agree, you will have to go to ECMO, but I would definitely not recruit this lung.
So when we talk about the refractory hypoxemia in ARDS, we are also considering what are the rescue treatment for the ARDS. As you told us that the patient will have to go for neuromuscular paralyzing agent. The patient might have to optimize the PEEP second. The third, the patient might have to go for a proning. The third, what Dr. Mace is telling, that the patient might have to go for inhaled nitric oxide. That will sometimes help. Some people also go for a transpulmonary catheter, a transpulmonary guided ventilation, and they optimize the PEEP according to the transpulmonary pressure. And finally, the patient might go for a ECMO. So these are the rescue treatments. Some has got survival benefit, like proning has got the most important survival benefit. Some has got not a survival benefit, but better for correction of the hypoxemia. Okay. So when we encounter those patients who are a refractory hypoxemia and not able to ventilate, our first priority is to prone the patient. And now if the patient is not improving and proning, then we are really in trouble. And then we have to think for those patients who may not have got a large impact on the survival, but might have got some improvement in the hypoxemia, or the trials are some. It is a gray area like Eolia trial and other trials which has shown that ECMO maybe have impact on the survival or may not have impact on the survival. That depends upon how you are analyzing the trial of the ECMO in ARDS patient. So one of the indications for ECMO is patient has failed to improve on the proning state. Okay.
Yes, sir.
Continue, please.
Okay. So this was day 3, sir. Patient was supine after 16 hours of proning, sir. And there was optimal decrease in the non-homogeneous opacities in the bilateral lung fields. And ABG showed the pH of 7.52, PaCO2 of 41, and PaO2 of 123, bicarb of 34, sir. This was on FiO2 of 0.5, and the PF ratios improved above 200, that is 248, sir. And here we stopped the paralysis.
So I have only one question at this stage, that we are discussing the ventilative management of ARDS, but how do you manage the fluid in your patient during this period of proning, supining, and giving all the treatment? How is the fluid balance was achieved?
So we
How do you
tried
guide the fluid therapy?
we targeted for negative fluid balancer.
Is there any evidence that negative fluid balance is got and
Fact
is
and
better?
catheter.
The fact trial has shown that what you try to achieve, that the at least conservative fluid, not a negative, conservative fluid may be helpful in improving the survival in those patients. Okay, fine. We'll go for next slide.
So the investigations for day 3 was hemoglobin of 8.50, sir, and RBC of 3.10 million per cubic mm, sir, and platelets of 2.46 lakhs per cubic mm, WBC of 4,220, RFT was within normal limits, serum electrolytes, potassium has come down to 3.2 millimoles, sir, and CRP has come down to 160 from 180. Patient sedation was decreased to 50 mics per hour of fentanyl, sir. Hypokalemia correction was given, and enteral feeding was continued at 60 ml per hour. The sputum cultures which were sent on the day 1 has showed no growth post 48 hours, sir. And oseltamivir was stopped on day 2 as the panel was negative, and patient was continued with the volume control ventilation, sir. This was on day 4, sir. We could see improvement in the chest X-ray with further decrease of non-homogeneous opacities bilaterally, and the ABG showed a pH of 7.48, so PaCO2 of 45 and PaO2 of 156 and bicarb of 26, with FiO2 of 0.4 and PEEP we could come down to 8 and tidal volume also at 350 with respiratory rate 20. The PF ratios improved from 240 to 390. So the patient was off sedation, and we started the breathing trial, sir, with pressure support ventilation of 8 PEEP and 8 pressure support, and rapid spontaneous breathing index was 74 for this patient. And as there was no hemodynamic instability and the patient underlying condition improved, and there was resolving hypoxia with the patient being awake, and we could extubate the patient to after spontaneous breathing trial, we could extubate the patient to nasal bronch, sir. Post extubation also, the vitals were pulse rate of 81 per minute and the saturation of 92% at 2 liters per minute of nasal bronchs, and respiratory rate of 28 cycles per minute, sir. This is day 5, sir, post extubation. The ABG on the day 5 was pH of 7.43, PaCO2 of 42, PaO2 of 160, bicarb of 26, sir, on 2 liters of nasal bronchs. This is the series of investigations day-wise, sir. So my final diagnosis would be aspiration pneumonia with moderately severe ARDS, status proning of 1 session, sir.
So again, the question is why you have made aspiration pneumonia as a diagnosis?
So my panel was negative, so as well as the sputums and cultures were negative, so patient has a history of binge alcohol 1 week ago, with the patient not knowing whether he had vomited or not, and with the
Okay,
cultures
so
and
there
panels
is
negative.
some gap. If we are considering aspiration pneumonia, there is some gap in the history which you are not aware that's why you have made a diagnosis of aspiration pneumonia. The second possibility is that once the patient has come to you, the patient might have received the antibiotic, and the patient's whatever the organism was there that may not be present at that time. Third possibility is that the patient might have some viral infection which has not been detected in the biofire. So all we keep in your mind, if you are not able to diagnose etiologically, then you cannot change the diagnosis. Got my mind? I still consider the patient has got a community-acquired pneumonia, and these things. Only thing which is against the community-acquired pneumonia, everything is suggestive. The patient has got an acquired sputum. The patient has got some change in the color of the sputum also. What you have mentioning repeatedly is that the patient never had fever. I've seen in the history also you have not mentioned, and even the patient came to the on NIV, and first investigation you have mentioned a temperature of 97.3 degrees, some 97.3, so it was afebrile. So
Yes.
whenever you are making any diagnosis, even for the treatment, even for the presentation, or when you are examined, that you should have the explanation, a true and truthful explanation. What is happening to my patient? Is exactly the aspiration pneumonia, or I have failed to diagnose as a community-acquired pneumonia? If I have failed to diagnose as a community-acquired pneumonia, that doesn't mean the patient has got aspiration pneumonia. Got my point? Okay.
Yes, sir.
Okay, and one of the question in the chat box is that what is the role and where is the role of steroid in such type of ARDS patient? Is there any role of steroid?
So, right now, so we are holding the steroids only for underlying ILDs and others. So we
Now, is there any role of steroid in ARDS or any severe community acquired pneumonia
Yes, with shock we can give.
or viral pneumonia? Sorry?
With shock we can give. And severe.
Shock, that is different thing. That is different thing. Shock with sepsis and septic shock, that is totally different. But have you heard about discovery trial? Recovery trial, sorry.
In COVID.
COVID trial. So what is that trial?
Steroids in COVID. No, like
So community acquired pneumonia, which is severe form, still empirical steroid in the early part of the community acquired pneumonia, people are using, and I don't remember exactly. I'll ask Dr. Ramesh that, which the study, if he remembers that, which
The
has shown.
Cape Cod study, sir.
Sorry.
I think it's called the Cape Cod study, no? Cape
Yes,
Cod.
yes. Yeah, yes. So there is some survival benefit we are using in severe form of community acquired. Anything, Dr. Ramesh?
No, sir. I think the steroids question will come up in the exam for sure, because examiners
Yes.
would like to ask you. It is a tricky question. There is no universal answer. I don't think if you put 10 intensivists in one room, there will be a consensus. But the answer is one, it depends on the etiology, right? If it's COVID, I think all of us would give steroids. If it is
Yes.
community acquired pneumonia, I think plus or minus still, I think even though the Cape Cod study came, there are some limitations, and the newer study has not shown the same outcome. So maybe some of us may give, some of us may not give, if it's a regular community acquired pneumonia. If it is a influenza pneumonia, there is data to say it worsens mortality. So probably I would stay away from giving steroids in influenza pneumonia. So one, it depends on the etiology. Two, it depends on the timing of the ARDS, right? Definitely, you should not give it after the second week of ARDS. If you're going to give it during the first week of the ARDS. So that is what it is recommended. So I would answer the question that way. It depends on the timing of the ARDS, and it depends on the etiology. I may or may not give steroids. So I think that's what we do in our ICU. COVID, everybody gets. Influenza, nobody gets. Community acquired pneumonia, depending on who's rounding, they get. Even within our institution, there is variability. So,
Yes.
That's what happens. Honestly, that's what happens based on the data. So I think that would be the answer that you'll probably get away with.
Yes, sir. So, yes, sir. Thank you for the insights, sir. Yeah, a couple of questions, sir. Like, especially nowadays, everybody like the update is to talk about the phenotypes, subphenotypes, hyperinflammatory, hypoinflammatory. So it varies. Yeah, the personalized ventilatory and non-ventilatory management of the ARDS patients. So generally, it is very difficult to differentiate between those two. Or what do you think, sir, Ramesh, sir, regarding this? How can we differentiate between those two and or the individualize the care towards them?
I don't think based on the tools we have right now at the bedside, we'll be able to comfortably differentiate the hyperinflammatory from the other phenotype of ARDS. I don't think we have reached a sophistication point where day to day I can customize my ARDS management based on my clinical pattern or the available biomarkers. I'm going to basically leave it there. I don't know if Dr. Vinod Singh has any other thoughts or inputs. Do you use anything else, sir? I mean, I know you looked at CRP every day. We don't even look at CRP every day. I mean,
yeah, that's one thing. What also we are doing, we are not able to actually classify into hyperinflammatory and other type of ARDS even at this stage. I think that has gone with the COVID. Now we are trying to find out. I guess there is some subset of patients who really does very worse and not doing whatever the treatment you give to them. Even on we put on the ECMO, the lung is not going to recover. I know, and I faced such type of patients also. But how to differentiate and how to find out those patients and what is the treatment option we are totally not very much knowledgeable about those things.
There are a couple of questions in the question box which we haven't answered. I think we addressed most of the questions.
Yes,
I'm just
sir.
scrolling through. One person has asked, how can you tell the height? How do you measure the height? Most people ask the height. Height is, I mean, most people won't know what their height is. It's an arbitrary height they give. So we don't go by it. Ideally, you should measure the height from the vortex to the foot. Basically, we look at the bottom of the foot to the vortex and measure the height, and then use that height for your weighing. The literature has looked at measurement of height and has described 2 or 3 methods. One is take a long tape and then go from the vortex all the way down to the foot, and that is what we do in our ICU. And we use that height as a cutoff for height, and then use predicted body weight. Some studies have looked at wingspan of patients. Again, reasonably easy even in a lying patient. There are some fallacies associated with it. But then people can have contractures. People can have contractures in the hip, in the knee. Therefore, if you just measure height from the vortex only to the foot, you can get a wrong height. So people have then also looked at measuring height in 3 or 4 segments. For example, vortex to the clavicle, clavicle to anterior superior iliac spine, from there to knee, knee to the foot, and then adding everything. That will avoid any mistakes if there is any contractures or anything. So we tried to compare these 3 things, and we found that the one point technique going from foot to from the vortex to the foot is the least the one where nurses make the least mistake. That is important, right? Because we are not going to be measuring it. Somebody is going to be measuring it. You complicate it too much, they make more mistakes, and you get wrong data. So we have just kept it simple. That's what most of the studies also will say, that go from the vortex to the foot and then use that height. So you should make it a point to at least get an accurate height, so that we can correct the tidal volume. Now, probably it's not that important, because anyway, there is a driving pressure as a secondary safety limit. And as long as your driving pressure is low and your tidal volume is reasonably within 6 ml per kilo, I think you're okay. So that was one of the questions that was asked by somebody. Electrical impedance is only one way of looking at the total body water. It doesn't differentiate intravascular and extravascular water. People have used it as a way of achieving negative balance, but I don't think it's routinely available in many places. It has been evaluated in CKD patients and then subsequently starting to come in the ICU. We have experimented with it for a while to try to diagnose, but most of us just go by a negative fluid balance. If you look at the FACT trial basically said conservative fluid strategy was a CVP of 4 or less in patients who are non-shocky. So that is a very simple definition. If the patient is non-shocky, try to keep a CVP 4 or less and maintain their fluid balance that way. I think that's what the FACT trial showed. And that showed that you would improve the oxygenation and get them off the ventilator maybe a day or 2 faster. But I don't think there was a mortality benefit in that trial. So that's the definition that we use in our ICU for simplicity. Should we have extubated the patient to NIV? What do you think? Dr. Pranitha and Komali, would you have extubated this patient to NIV? Does this patient meet criteria for extubation to NIV? I think this would be the last unanswered question, and then we'll stop after that.
So my patient was having good, we could achieve good PF ratio, sir, and there was no associated any comorbids or underlying diseases, or any fluid overload, so that I could take a trial of NIV, sir. I could reasonably extubate him to nasal bronchs.
So studies have looked at routine extubation to NIV. If you extubate everybody to NIV, it doesn't really help. Preemptive extubation to NIV doesn't work if you extubate everybody to NIV. Only high-risk patients. What most studies have said that is high risk defined as 2 out of these 3 risk factors. Age more than 65, underlying cardiac disease, underlying pulmonary disease. This patient was not 65, if I remember right. He didn't have
Yes.
underlying cardiac disease. He didn't have underlying lung disease. So doesn't meet criteria for an NIV extubation in this particular situation. So you can basically say evidence in this patient doesn't support,
Yes, sir.
like what you said. So that's another thing that we need to know.
Yes.
Just
I
two
think we'll
questions.
stop here.
Questions in the comment section.
A
Yeah,
lot of
just one-
questions are there.
Two questions to Vinod sir.
Yeah.
Regarding the ECMO strategy, sir, like nowadays more and more evolving concepts towards ECMO. Do you think it is reasonable that you assess a patient that is not going to be getting better even on prone and ventilation? So do you think early ECMO, even before proning, you go for ECMO early rather than even proning, causing further ventilator-induced lung injury and all? So versus give a trial of maybe 1 or 2 prone sessions and then go for ECMO. So of course, the affordability issues are those things. Suppose if a patient who affords and ARDS is so severe, probably other than the criteria, I think the patient requires more time to recover. Do you think going for early ECMO is better than giving a trial of ventilatory management and even with proning?
See, if you look at the management of ARDS, the impact of the Provisional trial, and even after the trial, on the survival is so high that we are not in a condition for any patient to denial of the proning. So my opinion is that each and every patient is fulfilling the criteria for the proning. Like if there is no contraindication for the proning, this must be prone even before putting the ECMO. Now, what further we are trying on the ECMO, that if you think that, okay, I can put my patient on ECMO and then prone it also, it is not quite possible that you put the patient on ECMO and then prone it. That what we feel, and that will be more, much more better than just giving a trial of proning for 3-4, leading to more ventilator-induced lung injury, and then putting on the ECMO. So there are trials which are going by putting a bicaval cannula in the neck and just put the bicaval cannula and prone the patient and manage according to the lung protective and proning guidelines and continue with the ECMO. And what we expect that should be better survival than first prone the patient, and if they are not improving, then put on the ECMO. That's what I feel.
Yes, sir. The role of ECR, I think there is one trial, Supernova trial, like they targeted ultra lung protective ventilation, even going further down to 4 ml per kg. The CO2 removal will happen with that probably.
Unfortunately, the Supernova trial was a feasibility trial, and that has shown that you can have. But the other trial, the rest trial, and those who has happened, that has not led to any survival benefit of patient who is on ARDS and just decreasing the tidal volume and putting the patient in extracorporeal CO2 removal. We are still in the process of finding whether it is to have any impact on the survival or not. And because a lot of complications that has happened in the rest trial, that's why this actually has not come into the practice.
Okay. Yeah, I think it needs further.
There is one question which once the oxygenation has improved with the optimal PEEP, is there any specific criteria of titrating the PEEP down to the lower value? This I will ask Dr. Ramesh to comment.
I don't think there is a specific guideline or an algorithm that universally is followed by all clinicians across. What we do is we try to get the FiO2 down to 40% or less before we start touching the PEEP. If you just look at the PEEP curve, if you just look at the pressure volume curve on a ventilator, you will see that you need a higher pressure to recruit the lung, but you will de-recruit the lung much, much faster. So that is something that you need to be very clear about, purely because of the way hysteresis loop works. So when you come down on the PEEP, there is a very high risk that you de-recruit the lung very quickly. And to re-recruit it back, you will probably need much higher pressures than what you were on before you started collapsing the alveoli. So I would be careful about my PEEP titration down. I would first try to get the FiO2 down to I mean, my preference is to 40%, something like that, or even less. And then work my PEEP down very slowly. Don't be too aggressive. Don't try to come from 18 to 10 in one day. Just be very careful because there is a very high risk of de-recruitment that can happen in these patients very fast. And then you'll go back all the way up again and catch your own tail. I mean, that has just been based on purely my experience, but that's the answer I'm going to give. I'm going to look out for Dr. Vinod Singh's input too.
Yeah, same thing. I don't go for rapid decreasing the PEEP, because again, what you told that at least the PEEP should be go down very slowly, and if you are not very much confident, you should go for the PEEP FiO2 table, and you can manipulate the PEEP according to the PEEP FiO2 table. Like if it is given in the PEEP FiO2 table that if you have 100% FiO2, you are getting PEEP of 18. If it has gone to 80, still they will consider 16 PEEP. So don't go very rapid decrease in the PEEP. That can cause de-recruitment, number one, and that can cause also more lung damage by repeated opening and closing of the alveoli if you are going PEEP too low in cases of the ARDS in too early stage. So very rightly pointed out by Dr. Ramesh that it is not going to harm your patient. Even your patient's oxygenation has improved. Be very, very careful in titrating your PEEP towards the lowering. That's what.
So I think, yeah, much have been discussed, sir. One last, I think, recruitment maneuvers, sir, like in case of very sick and hypoxic patient. What is your thought process, sir? The most of the times, yeah, most of
If
the
you're asking me, Dr. Kalada, I don't do this practice of recruitment in ARDS patient. What I feel is that the slow recruitment by proning, that is the only way, and that is the best way to manage those patients. I don't recruit. I have stopped recruiting since last 5 years, and not only me, in my hospital, my institution, nobody does the practice of recruiting the lung.
Yeah, so same here. I optimize the PEEP based on driving pressure and stress index once I paralyze somebody. And if I am not able to achieve my endpoints, I go to quick proning. Within the first 2 hours, 2 to 3 hours of ventilating somebody, I would go to prone and I'll prone them till they get better. And if, like Dr. Vinod Singh rightly said, even after proning, I'm not able to achieve the goals, then I quickly think about ECMO. So that's what we do. If some people, you'll see that they improve with proning, then you supine, they get worse. So we do prone. And what we have decided is, if you look at the Prosiva trial, the average number of prones anybody requires is close to 3 prones, which is about 72 hours of proning roughly, right? So 20 hours each. So that's what we do. We allow them to prone 3-4 times. In the COVID era, we have proned so many times. But somewhere around the third proning, we also involve the ECMO team to think about those options as a multidisciplinary goal and say somebody is not improving as much as we think, should we go for ECMO early? So those is what we would do. We don't recruit routinely for all ARDS patients.
Regarding last question, sir. Regarding newer modes, there was much enthusiasm about APRV ventilation, the PAV, and yeah, of course, I think most of them doesn't make much difference. I think future it's going to be AI guided ventilation. So what do you think, sir? The future is going to be another 5-10 years, especially the ventilation part in ARDS patients. Any of you can answer, sir.
Yeah. See, whatever the trial so far has done, it has not shown any benefit by ventilator mode. If we are using APRV mode, whether you are using the pressure control mode, whether you are using volume control mode, that is not has shown any survival changes, survival benefit. APRV mode has got some benefit in improving the oxygenation, but lot of dysynchrony is there in a patient who is ARDS patient. If you put on APRV mode, actually they will have a lot of dysynchrony, and we have seen in COVID time a lot of pneumothorax also people the patient on APRV. But there are people, even in my institute, they would like to put the patient on APRV. The problem is that many nurses, many technicians don't know how to handle the APRV. Because something happens to the APRV, suddenly the patient will be going back to the pressure control mode or the volume control. That is a problem with the APRV, because if the team is not tuned to put the APRV mode, then once it's got some problem. But according to the literature, what I feel is that there's no much impact on the ventilator mode on the survival of the ARDS. Maybe some hypoxemia is better. That's what I know.
Dr. Ramesh, sir, any final
Yeah,
insight?
that's the same here. We have tried APRV a few times in ARDS. We didn't see good results. The data is very clear. And there's one pediatric study from PGH Chandigarh that showed outcome benefits in children, but the biggest study in adults actually showed adverse outcomes in a Chinese study or something like that. So we don't use APRV at all as one of the initial modes of ventilation when the patient is acutely sick. So that is number one. PAV, again, we don't use it in acute ARDS, but sometimes as we are weaning the patients, if they have a lot of dysynchrony on regular pressure support, then PAV would probably make sense because you're probably trying to give a proportional assist at that point of time. And we have used PAV more as a weaning when patients are completely dysynchronous with a pressure support mode, and use PAV as a weaning mode rather than in an acute setting. And again, we have used it very sparingly in selected patients where there is a lot of dysynchrony on pressure support and we are unable to do a pressure support wean, like what we would normally do.
Thank you very much, sir. I think we had a very good, nice discussion, sir. More than 100 people logged in and with very good active interaction from the participants. So thank you, Dr. Ramesh Venkatraman, sir, and thank you, Dr. Vinod Kumar Singh, sir, for providing your clinical insights and had a very good, interesting discussion and many good feedbacks. So thank you, Dr. Pranita and Dr. Komali for bringing out that case to have a
Thank you, sir.
discussion. And I thank the Yashoda hospitals and our digital branding team for providing this platform. And I thank Dr. Venkatraman Kola, sir, is the mastermind behind this masterclass. With continuous support, we are able to do it and is the driving force behind. So I thank you, everyone. And thank you, sir. Thank you very much. And good night.
Thank you, Kaladhar, for the opportunity. Good job, Dr. Pranita and Dr. Komali. And nice seeing you, Dr. Vinod Singh, at least virtually. I'll see you sometime soon in person.
Thank you.
Thanks to everybody. Thanks to everybody.
Bye.
Thanks to Dr. Pranita and Komal for presenting such a nice way. And best of this, my best wishes for you.
Thank you.
Thank you, sir. Good night.